Cool. Looks like we have a quorum. Let's get started. It's my pleasure to introduce Kayla de la Haye, who is an associate professor at USC, working on social network analysis and system science, in particular looking at how social networks influence health promoting activities and things like diet and physical activity, both within families and communities. And we're delighted to have her to speak to us today about the connection of social network analysis and mobile health. And I'm really looking forward to this talk. Kayla, all yours.
Thank you. Thanks so much for the invitation to be part of this great institute. I see a couple familiar faces in the group that is participating, so it's nice to see you all, and nice to meet everyone else. I will go ahead and share my slides, and similar to Pidja, I will please interrupt and just speak up if you'd like to ask a question while I'm talking, because I'm also on my laptop and may not see all the chat. Is that showing up okay? Great. Okay, so I have a few goals with the session this morning. One is just to talk a little bit about why we're talking about social networks, why they matter to health behaviors and health interventions, and to give a really brief but hopefully useful overview of social network analysis and theory. And then to talk more specifically about what social network analysis looks like when it's applied to health and mHealth research. And then finally, to give some examples of how social networks can be addressed in behavioral interventions that leverage mHealth technology. Okay, so for those of you who haven't worked in this field before, I want to make the case that social relationships and the networks that we're embedded in really matter to health behaviors, to people's health outcomes. They also influence how health practice and policy is made, and they play a really large role in structuring health disparities. And there's a huge body of literature now looking at emergent structures of social networks and how they are associated and influence and can be leveraged in these different types of health outcomes. And one of the more compelling pieces of research, I think, is this meta-analysis by Holt-Lundstad that looked at social connection and social relationships and the impact on mortality across 150 different studies, and found that social connections impact on mortality, in fact, looks to be larger than many of the established risk behaviors we look at, like smoking, obesity, and physical activity. So this really matters to our health, and it's often something that we neglect as part of health interventions. And so my view on this is that we have a couple of options. We can let network scientists continue to study social networks and learn about their structure and phenomena, or we can do more work to foster transdisciplinary scientific teams where folks working on health behavior and health behavior change are working closely with people with expertise in social networks, so these things are studied together when we are looking at health phenomena, and so that we better understand how to leverage and address social networks when it's useful to promote good health and address health disparities. So I'll be advocating for option B today, and hopefully it convinces you as well. So I'm going to, for those of you who have some background in social network analysis, this won't be too much new information, but I want to give just a really quick snapshot of what I mean by social network analysis and some of the jargon and techniques that we use with these methods. When I refer to social networks, I am referring to social structures that are made up of social actors. So those social actors are often humans, but they might be organizations or even countries. People study social networks of dolphins and chimpanzees. So we're studying these social actors and specifically the relationships among those actors, how they connect with each other and interact. And there can be a lot of different diverse types of networks and social actors that are studied, things like kinship among community members, friendships among students, advice seeking among colleagues, retweets in Twitter networks, how organizations collaborate with each other, or even partnerships and communication among countries. And often when we look at social networks, we refer to them in terms of graph terminology. So we often represent them as a graph like you see on the right here. And in these graphs, people or the social actors are represented as nodes in this network. And the relationships, whether or not someone's friends or coworkers or even enemies, are represented as these ties. The ties could either be directed, where I say someone's my friend, but they don't nominate me back, or they might be undirected relationships, like we have a family biological relationship. And then social network analysis is a set of analytic approaches, largely based in mathematical graph theory, that's used to study these social structures. And so there is decades of research looking at social networks and multiple decades of work looking at networks in relation to health. Here's just a few examples of the types of networks that have been studied. On the top left is a network of sexual contacts. So here the ties represent sexual relationships between people that have been used to study the diffusion of STIs. In the bottom center is what's called a two-mode network. The red nodes are people and the green nodes are park or public spaces within their community where people walk their dogs. And the relationships represent co-location between people in these different park spaces as they're out walking their dogs. And then the top right is a network from the well-known mHealth research study. This is one high school in the 90s where the students in that high school nominated who their close friends were. This has been used to study a lot of health outcomes. And in this graph here, the node color is represented by the students' race and ethnicity. And there's a couple different perspectives from which we study social networks. One is at the personal social network level. Here is where we're focused on measuring social ties that surround a specific individual. So it's focusing on a person or an ego, and often we, like in traditional research, would get a sample of individuals or egos that are part of our study, and then we measure the relationships that surround each of these egos. We call those people that they're connected to the alters, and we also measure the ties among those alters to understand the structure of the network that they're embedded in. The example on the right is a great study by Amar Dahand at Harvard, who's a physician and has found that the structure of these personal networks in his patients predicts how quickly they come into the hospital after a stroke. People who are in more constrained networks tend to take longer to come in after a stroke event. At the other perspective is thinking about complete or sociocentric social networks. And this is where we want to study the social ties among all people who are in bounded group. So that might be a school, an organization, a specific community. And as researchers, we define the boundary of that social group of interest. And then our intention is to measure all of the social connections, either their presence or absence, sort of like a census, among all people in that group. And so in the bottom left here is a classroom friendship network that was measured. And this was part of a study where multiple classrooms were studied. And so we have multiple networks of friendships across different classrooms. Here, just to contrast what these two perspectives show you is an egocentric or personal network from Facebook on the left, So this is one person's friends or alters, and how they're connected to each other. You can see that there's a lot of structure in this personal network, where there's clusters of people in their personal network who are tightly connected to each other, but there's separate groups of these people and some more isolated alters in their network. So that's a personal network of one Facebook user. On the right is a sociocentric network of all Facebook users. So here, the light ties represent all of the connections among people around the world, the many billions who are using Facebook. And I mentioned at the beginning that one of our real goals with social and network analysis is to understand the structure of these networks, because these structures hold a lot of emergent meaning for the group of people that are in this network, and also for a given node and their position within this social structure and what they might have access to or be exposed to given where they're located in a network. And so when we think about structure, structure is really built up of features at a dyad level between two people that come together to make these emergent network structures. So at the dyad level, a relationship might not just be there or not. There's some complexity to it that we might want to measure. I mentioned before that we could think of ties being directed or mutual, where a friendship goes one way or both people agree that they're friends. We might also think about the intensity or strength of a relationship and measure, for example, how emotionally close people are or how frequently they have contact with each other. And lastly, we can think about the complexity of these relationships, where there might be multiple types of ties at the dyad level. So the green tie here may represent people who are biological family members, but the black tie represents the alter on the left seeking support from the alter on the right. So this could really build up into very complex and emergent network characteristics. And there is literally a social network Bible that is huge, that lays out the many, many mathematical configurations and network structures one might be interested in. But I'll just highlight 4 key ones that we often look at in health research. One is at the network level, thinking about the density of the network. This is simply the ratio of ties that we've observed among this group of people compared to all possible ties if everybody was interconnected. And so clearly this matters a lot for how things might flow through the network, information or contagious diseases. Another feature is centrality, and this represents that there are nodes or social actors within the network who have more connections or more ties than other nodes. Here I've highlighted the students in this classroom friendship network that have the highest number of incoming friendship ties. They're the most popular in this network. And these might be really key people for influencing others or spreading new information. Another feature of networks is clustering. It's very common in social networks, particularly human social networks, that people cluster into more densely connected subgroups or cliques within the network. So this mathematically is represented by a higher density within particular subgroups of the network compared to a lower density across those groups of ties. And so here you can see a few different subgroups within this friendship network of more tightly connected friends. And then lastly, a number of network characteristics we might be interested in are at the intersection of the structure of the network itself and the characteristics of the nodes in the network. Homophily is one of those where there's a common phenomena that ties among nodes in a network tend to form between people who are similar on a range of socio-demographic attributes, and we've also found similar on a range of health attributes. And this is kind of the colloquial idea that birds of a feather flock together. And so if I told you that this was a grade 8 classroom friendship network, you might be able to guess that gender is the node color here, grouping these students. And so when networks become really interesting is when we think about how these structural features come together to explain emergent phenomena in these networks. One of those is how we could better understand group membership. So there's a lot of research documenting this tendency for homophily or preference for similar others in social ties. And we also tend to see this phenomena of clustering into subgroups of these homophilous individuals. So dyads sort of form who are similar to each other, friends of friends become friends, and these subgroups or cliques form that tend to have clusters of more similar groups of people who then differ or have different group identities to other groups in the network. So these are often important structures that we work with for health interventions because they may embody different group identities, health behavior practices, and strongly influence one another. Within those groups, there's also often emergent group opinion leaders. So it's very common that within a group that there's certain members of that group who are more central. They have more ties or are more popular within the group. And these central members play a really important role both in influencing other people. They tend to have high social prestige and may be able to influence others in the group. But they also tend to be constrained by group norms in some way, particularly if we think about adolescent peer groups where the popular kid within a clique or a social group may be really reluctant to deviate from the behaviors that are normative within that group with the risk of losing their social status. These members, these central opinion leaders are often really key focal points for network interventions when we're thinking about who to engage with in the context of a network. Okay, I want to see if there's any questions that have popped up at that point. Not yet. Okay. All right, I'll move forward. Okay, so when I first learned about all those structures, I thought, oh, that's really fun and interesting to map all these networks that people are embedded in. But really the critical question and why you're all here to think about health interventions is why would this matter to people's health? And the key answer is that these social ties and networks serve a lot of functions. They're essentially the social pipes through which a lot of social phenomena flow that we know and have a lot of literature and evidence base are really important to people's health. So they're the source of contagion, of the spread of ideas, emotions, or things like infectious diseases. They are the source of social influence, so they can change people's behavior due to perceptions about what others around them are doing. Social networks are a source of social support, providing aid or assistance that might be exchanged through these relationships. And broader social network structures can be really useful in understanding access to larger social capital and whether there are resources and norms that are being distributed through networks that someone might have access to. And I think an important thing to note is that networks are not always helpful. Who people are connected to and where they're embedded in a network may help or benefit their health, but it may also be a source of unhealthy social influence sources, a lack of support, or they may be exposed to social undermining, aggression, interpersonal conflict, the experience of racism. These things play out within these network structures and through these pipes and relationships that we can study through network science. And so really a key point is that we have a lot of tools to measure how people experience these phenomena at an individual level. And what social network analysis and tools provide is a way of really mapping out these network structures and people's position within these emergent networks that really affect their exposure to these different types of functions, and whether or not they have access to or are exposed to these health impacts. Here's one example of thinking about these emergent phenomena within social networks. So there is a theory of the strength of weak ties in social network science that has been studied in a number of contexts and has really documented that our strong, close-knit and most densely connected networks tend to be these small reciprocal groups of relationships around us that on average tend to be good for people's general health and are often a key source of support and resources. However, these strong ties tend to be homogeneous because of homophily. They tend to provide redundant and the same types of information or resources, and they can reinforce strong, potentially unhelpful norms. And so there's a benefit to also having access to weak ties, these larger, more diffuse, heterogeneous networks that are more on the periphery of our network, that tend to offer more diverse and novel information and resources. And there's been a lot of research showing that these weaker ties can be really helpful during a transition or crisis when new or novel information is needed. And they may not be a source of everyday tangible support that sort of helps people get through maybe a day-to-day illness or day-to-day support that they might need. So just to sum up, there's a social network analysis. When I use that term, I'm really referring to a set of methods, which I haven't really touched on here, only just briefly. These methods are both descriptive, so things like describing the density of a network, but there's also a huge suite of inferential statistics to model social networks and test network hypotheses. And this is a set of methods that are largely quantitative, but there is quite a body of mixed methods research in the social network literature too, that are used to measure and understand social networks and their relationships to people's and groups' outcomes. Social network theory is really a body of work spanning from the 1940s that have used these methods and really built up a theoretical framework that has the premise of people being embedded in webs of relationships, and that individuals and the relationships and networks they're embedded in are very interdependent. And so it really makes the argument that they shouldn't be studied in isolation, sort of what we tend to do when we sample people in a typical study and assume that each person in our data set is independent of one another. Here, the goal is to really explicitly model those dependencies and understand how they matter to health. And here's a few examples of different types of network theories that you may have heard of. And in terms of health applications of social network analysis and theory, there's really kind of two key areas. One is more observational research, where it's research trying to understand the impact of social networks and social relationships on health outcomes and behaviors. And then a second line of research that has really been pushed forward in the last decade or so, designing health interventions that use social networks, structures and functions to try to support health behavior change. And lastly, just to touch a little bit on the data that's captured with these sorts of studies, social network research requires that you collect information both on the social actors, like we normally would do about their demographics and behaviors, but also that we collect data about the relationships among people. And the research questions that you have should really guide which type of information on the actors, obviously, but also on the relationships that you're looking at, that you're going to collect in your data. And common data collection strategies include surveys. This is a really common tool that include what are called name generators, where you'll have a question that asks people to perhaps list their friends in a classroom, to list their colleagues that they do physical activity with, for example. Also, observational research, particularly in more mixed method studies, is common, where people might observe social relationships. A lot of social network analysis stems from anthropology, and there's some really rich field studies studying and mapping social networks using those tools. And increasingly, there's work with the explosion of data available that shows traces of social interaction, efforts to mine existing data sources that range from email and phone records and people's communication through those tools, to mining Twitter and Facebook data to understand social connection and interaction there. And then lastly, there is growing interest and work on sensor data, using mobile sensors to capture social interactions between people in a more passive way. And I think probably what's most exciting is thinking about the combinations of these different tools and sort of the richness of perspectives they might provide us on not just social contact, but the meaning of social relationships and what flows through those social networks, given people's contact and interaction across these different domains. Okay, so I'm going to transition into some of the more applied examples. Any questions popped up in the chat? Not yet. Okay. Oh. Okay, so I'll speak more concretely about some research I've been more involved in the last 10 years that thinks about social networks in relation to eating behavior and how to promote healthy diets. And so just to frame the problem space that I've been working in, among American adults, we've been trying to promote healthy diets for the better part of a decade, and largely been pretty unsuccessful. About 1 in 10 adults eat the recommended servings of fruits and vegetables, and 1 in 3 American adults are currently consuming fast food on a daily basis. And each month, about 44,000 adults die from diet-related diseases, largely through their role in contributing to diseases like obesity, diabetes, cancers, and heart disease. And so diet-related diseases is really one of the huge public health problems that we so far have had a really hard time changing at the population level. And this is sort of the common set of results we see in dietary and obesity health behavior change programs, where even in the best gold standard programs, for those people who can participate in them and stick to them over time, even for those folks, we tend to see this triangular relapse pattern, where people are able to change their eating and exercise behaviors for a short period of time, but they have a really hard time sustaining these post-intervention and really in the long term. And I'd argue that this is because for short-term changes, people are able to exert agency, effort, they're able to take on new skills and really, put a lot of effort in to make different choices and change their behaviors in the short term. But all too often, people are put back into social and ecological settings that influence these health behaviors, but do not support these healthy changes in the long term. And this is especially true for certain segments of the population, people who live in rural areas, folks who are low income, and communities of color are disproportionately exposed to structural forces that make it really difficult to maintain these behaviors in the long term. And so these types of everyday habitual behaviors like eating that are really sort of outsourced and influenced strongly by the environments that we're in, I think really need to pivot towards this more ecological approach to thinking about behavior change and how influences across these many different levels, including the social environment, are shaping whether or not people can change these behaviors and keep these behaviors up, and need to be the focus of our intervention strategies to think about how we're creating structural environments that are going to support behavior change in the long term. And one area that has been, I think, underemphasized and neglected in some of our interventions is the social environment. And just recognizing how much eating is a social practice, something that we do often with others, very much dictated by what's normal, our cultural preferences, what people around us are doing, and sort of the social rules and resources around about eating around us. And there's a really long history of research on this topic, but social network analysis has been able to provide some new insights into how complex social structures can shape eating. We have found that increasingly we eat in diverse settings with many different eating partners. Americans in particular are eating more food away from home, fewer family meals, and eating with varied people in our social networks. A lot of our research has found that people eat with about, on average, a quarter of the people in their close personal networks that include nuclear family, but also extended family and friends and coworkers. We have found that among Mexican American adults, having personal networks that have structures that are more transitive, meaning that there's more friends of friends who are friends and social connectivity in that network, as well as more networks that have more people or greater proportion of people that provide health support, that can predict better diet quality, especially for those people with who are experiencing food insecurity. Another example in a pilot study looking to test a new intervention for low-income mothers and their infants to prevent childhood obesity, we found that the personal networks of these mothers and the structure and composition of them moderated the impact of our lifestyle intervention after 6 months. And so we found that low-income moms in our study had better outcomes, as did their infants, in terms of diet and weight, if a greater percentage of people in their personal networks supported them in having a healthy lifestyle. And another example is using longitudinal network analysis research, where we study how health behaviors and networks change together over time. And so in this study, we found that among adolescent friends, these are grade 8 students, that when we look at their friendship networks at school and their intake of low nutrient, energy dense junk foods, that there was a lot of correlation or similarity among friends in their intake of these foods. And when we modeled this over time by collecting social network data and dietary data at multiple time points over a year, we're able to use social network models to explore, what's creating that similarity. And we found that a lot of factors predict who becomes friends with whom. Things like similarity in gender, socioeconomic status, obesity played a large role in the structuring of these friendship networks, where there was a lot of weight-based stigma and homophily around obesity. And we found that the similarity in intake of junk food was really driven by social influence mechanisms. So accounting for all these factors that explain how these networks form and change over time, we saw that adolescents who were friends with kids that were high consumers of junk food tended to increase their intake over the course of a school year, controlling for their own personal preferences and beliefs about junk food and their own sociodemographics. And so what we find in this body of work around social networks and health and healthy eating is really that these are interdependent systems. People tend to select social ties with similar health risks for a few key reasons that are listed here. I've mentioned homophily, so this tendency for people to connect with others who are similar on sociodemographics creates correlations in a lot of health risks among socially connected people. Propinquity means that people tend to connect with others who share the same spaces geographically as them. And so the way that people are spatially sorted in communities and the opportunities they have to connect with others also creates similarity among socially connected individuals. And lastly, stigma often plays a really large role in isolating and segregating certain groups of people within networks. We found that this is really prevalent for weight-based stigma, where individuals who are overweight tend to be pushed to the periphery of networks and connect with others who are overweight. And so this is structuring these networks in a way that's sort of concentrating health risks among similar groups of people. And over and above that, we find evidence that these social ties and people's position in the network also influence their health behaviors, including eating behaviors and related diseases, through these different social mechanisms. And so to me, this really highlights this important feedback loop to think about in our health interventions, where people who may have the greatest risks for certain health outcomes tend to be embedded in networks that also confer similar health risks or lack of resources. And that goes on to influence their health or their dietary health. And so it's really this feedback loop. I've thought a lot about how we might disrupt this in our interventions or intervene on key points in this system that are going to benefit people's health. And I think where there's a lot of opportunity to think about with this group is how we leverage mobile health technology and more rich sources of data on social connectivity to be able to do that. I'll just do a quick check for questions. Did anyone have one that they wanted to shout out?
Sure, I can ask a question.
Great.
Can you assist with understanding how the data was collected for some of the work you just presented?
Sure. So most of the, I think all of the work I just presented was largely collected by survey data. And so as part of studies, as part of intervention work, as part of research in school-based settings, there would be a survey component that asks people questions about their social relationships. So in the case of the adolescent friendships, we were working within whole schools. Let me click back onto that image so you can see it. So in this study, we're working with a whole school and a group of students. This cohort was in grade 8. And so we include a survey section about their friendships at school and ask them to nominate or list the names of the people that are their closest friends at school. And so on average, people would nominate about 5 friends, but some students name none, some students name 18. And we capture their friendships that way. We also ask some other questions about those friendships, like how close they were, how frequently they have contact. And then we measure that at each survey wave. So we have snapshots of the network over time. In the personal network studies like this one, so this is an intervention where we have a sample of moms going through this home-based obesity prevention program. It's embedded within a home visiting program. And here we don't have a group of people, so this is a personal network study. And so the same thing here, this was survey-based questions where as part of the data collection protocol, at baseline and at follow-up, moms would be asked to enumerate who are the important people in their lives and to name up to 10 people. And then because those people aren't in our study, so we don't know what those people are doing, we have to ask the mom a lot of questions about the people that she nominated. And so these personal network studies are a bit more intensive for survey data collection because the mom reports on, you know, the demographics of each of the people she names, whether or not they support her, if she eats with them, if they exercise with her. So we capture a lot of characteristics about people through the mom's report. And so these studies here are all survey generated, and the next section is where I'll talk a bit more about, I think, opportunities for mHealth and other approaches to gather richer data on these social ties.
Thank you so much.
No worries. Any other questions before I move on? Okay. So a few things that I think that was a great question, just to pivot to this next section in thinking about what are the opportunities for mobile health to really innovate in this space. So in social network research, we have relied a lot on traditional survey data, data that's captured at snapshots in time when people are given these surveys at 0 months, 6 months, 12 months into the study. They can be very resource intensive, particularly those personal network surveys where people have to really give you a lot of information about the social networks that they're embedded in. And they do have a lot of limitations in their scope. Thinking about if you're just kind of capturing the social networks that surround a person, but we don't really know what's going on in their networks beyond that, or online, or in their community, or in the case of the friendship networks in a school, we're sort of focused on this little microcosm of friendships, but not thinking beyond the social relationships that we've defined in that study. And so I think what's missing from this, and where there's opportunities with mHealth, is to think more about spatial and temporal dynamics of these relationships, to look more into multi-levels of these social systems. So how social networks and social interactions are playing out, and in what settings and environments that's happening. And then also opportunities to leverage passive sensors and secondary data that I think would really complement data we can get from surveys, by giving us a richer picture of things like social contact and interaction that we may not be able to get people to report on accurately. And so I'll give a few examples of work in this space, and then end with what I think are some maybe exciting opportunities that you all may take up. And so a few different sources of mobile or big data, I think, that could be useful in the space that I work in the food space, are listed here, and I'll start with mobile health sensors. And so this is a study I conducted with a team of mHealth experts, which I do not consider myself. I consider myself someone who really values working with people with expertise in mHealth. And this study was funded by the National Science Foundation's Smart and Connected Health mechanism, which I know someone was asking in the last talk about funding opportunities. This ended up being a great one for building a custom cyber physical system to do the mHealth sensing that we wanted to do. And the goal of this project was to monitor family eating dynamics, to really look at eating behaviors within multiple people within a family system, and to monitor social as well as individual factors that we thought were important to understand family eating in real time. And so the system was designed to detect eating events in real time, We spent a lot of time and had a lot of bugs, and it was a really large team to develop first in the lab and then calibrate in the wild an algorithm for a smartwatch that would detect bite motions and thus eating events for children and adults. And this watch was deployed in the wild to then trigger in families' homes EMA data capture about mood and other aspects of the eating event. And we also had beacons in the home that were capturing the spatial location of the multiple family members to understand their co-location and joint or alone eating events. And so this is what the system sort of allowed us to capture. It was deployed in about 40 families over a 2-week period in Los Angeles, capturing over this 2-week period bite rates and eating rates over time that allowed us to code for eating events for each person in the family. And then simultaneously, this was triggering and capturing data on things like mood, satiety, eating in the absence of hunger, and the beacons were capturing this co-location information. I'm going to talk about this really briefly and then point you to some papers, but I want to highlight that this type of custom-built sensor gave us some new insights into the social dynamics of eating within these family systems. So one thing that we found within these families is that 2 out of 3 eating events at home involved eating with other family members. We also were able to detect bite mimicry. So because the smartwatches were detecting these eating events and bites across multiple family members, we could see in real time and out in the wild that there was imitation or mimicry occurring, where if person I took a bite, there was a statistically significant probability that person J would take a bite more quickly after they just observe the person they're eating with take a bite. We used relational event modeling to look at how these sequences of events across multiple people played out over the 2-week period. And we found things like eating alone and having negative affect was a common class of eating events that tended to occur within these family systems, and that affective state inertia, or the persistence of positive or negative emotional states that's been observed in the literature, we found that that tended to persist in these family systems, whether people were eating alone or with others. So I've pointed to a few publications on the bottom here. The purpose of this study was to really build this system, to get it to work and to see what we could learn about family systems and their eating behaviors using this tool. And a next stage of work on this would be to leverage this to do M3 fed, which would be not just to monitor and model, but to modify family eating events more in real time and leveraging some of these social phenomena that might matter to people's eating. One other example of work that is a newer project I've been involved in has been leveraging smartphone mobility data, which provides mobility traces or geolocation for large numbers of people in the population. We've been working with MIT Media Lab and a data set from Cubic, and focusing in on about 700,000 residents of Los Angeles County over 6 months, where we can use this data to really observe people's mobility over the course of that 6-month period, and identify their patterns of movement, as well as by linking that data to point of interest databases, we can study their exposure to mobile food environments, both social and physical, and observe their visit to food outlets with these sort of billions of pings of geolocations. And so we're thinking of this as this opportunity to really objectively measure food environments, not just in the home environment, but beyond the home and in people's neighborhoods, workplaces, and communities where they go and eat. And so some of the goals of this project, by linking these mobility data with point of interest databases and health databases, has been to characterize these spatiotemporal patterns of food access and map where people are going to get food, but also their social encounter networks during this food access. So sort of the built environment and social environment exposures that they have while they're getting food, and explore how this links back to people's nutrition and health. And how we're able to do that with these large data sets is really at an aggregated level. So we have to describe this data really summarized at either a point of interest level or aggregated up, describing, say, groups of people in a census tract or a particular area, what their mobility patterns are. And because we can't link individual mobility data back to someone's health record, we need to do that at an aggregated level. So again, talking about mobility patterns, say for a census tract, and linking that back to diet or nutritional outcomes at that census tract level. I know there's exciting work doing this at a smaller scale on individuals, capturing GPS location at the individual level, where you can then link that back to people's health outcomes. And there's more of a challenge there in capturing social encounters, unless you're really able to design and get funding for a study that, say, puts everybody in LA County, gives them one of these devices, and is able to track them and their social encounters. So I think that's one of the challenges and opportunities I'll talk about at the end. Lastly, this is not a space I work a lot in, but I just wanted to mention it, is there is rich work on social media data, leveraging information about social connections and social networks on social media and looking at them in relation to health outcomes. I just mentioned a couple here that are focused on diet, that have found, interesting effects of influence on both healthful and unhealthful eating practices through social media ties, and the way that social media operates to perhaps perpetuate or provide social validity to unhealthy eating practices through likes and approval messaging on social media. The last thing I'll end on is a study that we've just kicked off. The National Institutes of Health Office or the Common Fund at NIH has recently funded an initiative called Nutrition for Precision Health, that leverages the All of Us research infrastructure. And I'm a collaborator on one of the clinical centers and MPI for the AI and modeling center that's part of this consortia. And the premise behind this is that there's recognition that there's no one size fits all diet, and there's some real potential benefits to thinking about nutrition from an individualized perspective. And so the goal of the Nutrition for Precision Health, or NPH initiative, is to build on advances in biomedicine, in AI and modeling, as well as microbiome and other physiological research, and really leverage the All of Us research infrastructure that has, if you're not familiar with All of Us, has this huge infrastructure across the US, enrolling 1 million Americans to study their health and health outcomes. And so what this program intends to do is generate new data and algorithms that are going to predict individual responses to food and dietary pattern, and also advance the science of precision nutrition for the population as a whole. And so I've been involved the last month working a lot on the protocol for this study. In particular, how we are going to measure social network and social ecological factors that matter to diet and nutrition in this in these 10,000 diverse adult participants that are going to be part of this consortia. So they'll be getting enrolled starting next year. And there are a huge battery of measures that are going to be captured for these folks. They are going to be, given meals and diets, and their diets that they typically eat are going to be measured. There are a massive suite of physiological measures that range from lipid testing on bloods to microbiome to glucose monitoring, a suite of behaviors that will be measured, and household factors. And what I've been working on is how we're going to measure social networks, social determinants of health, and broader ecological contextual factors that matter to diet and diet outcomes. And so there's going to be a lot of survey tools and sort of traditional methods for getting people to respond to lengthy survey data about all of these phenomena. But there's also some really exciting integration of mHealth, particularly the group leading dietary tracking, using smart glasses to capture when people eat, and capture photography information about not just what they're eating, but also the context of that eating, including things like who they might be, if they're eating with other people or not. There is a proposal to do GPS tracking on all these folks so that we can understand where they're spending time, where they're going to get food, and really link this back to where they're actually eating food. And then there's open discussion about how much or whether EMA can really be integrated into a study of this scale. And so that's really to be determined. And then the other exciting data sources are thinking about how we can bring in secondary data into this. So electronic health records. We've been exploring opportunities to try to scrape de-identified information about social media and the social structures that people are embedded in. And by tracking GPS, we get some really rich information about the geographic location and social context that people are spending time in, and can draw on a lot of rich data sources about those social or built environments that we could then link up to this individual data. So I think this is one example of a study I'm really excited about, where there is some real opportunity to track multifaceted social environmental exposures and how they're impacting diet. So I want to end with just what I think are some of the challenges and opportunities with this work and innovations of mHealth capturing social phenomena and social networks. I've seen a kind of studies at either end of this scale or these trade-offs where there's smaller studies of 100 people or less that have really intensive capture of individual or small group network data, where people may be equipped with social sensors or really rigorous EMA protocols to capture social interactions and social context that people are in when they're doing health behaviors, and to capture that over time, and even perhaps link that to something like geolocation and the environments that people are in. And then at the other end of the scale is the really rich population data that we have, traces of mobile phone records, mobility data, social media data, where we have really interesting informative phenomena about social connectivity and interaction and structure at large population levels. But also often we can't link that back down to an individual health outcome very easily, if at all. And so often with those studies, we're thinking about how that links up to more population level metrics and health indicators. And so where I think there's some really exciting opportunities is how we might use mobile health and these different streams and sources of information to bridge some of this micro macro gap in understanding social network phenomena and how they relate to health. So the last slide or two, I'll just touch on a few examples of social network interventions. And there's been some great work written about providing typologies of social network interventions by Tom Valente. The science paper is a great brief summary. And This paper summarized 4 different types of network interventions that are typically done in the health behavior space. And I'll send these slides to you all, but I'm going to give examples on the next slide in a little more detail. So the first type of network intervention, the one that we tend to find most commonly applied in network intervention approaches, is called identification, that typically focuses on identifying opinion leaders or people who are structurally central or central group members within a network, with the notion that they have the highest reach and the highest potential influence to diffuse an intervention through a network. And these might be people like family health promoters if you're working with family systems, or peer opinion leaders if you're working in settings like schools or organizations. This network on the left is a friendship network of a grade 8 student cohort. And here the nodes are colored by physical activity. So the green nodes are those kids that are most active, and red are the kids that are least active. And we could think of, using this network to identify subgroups within this network, clusters of kids who are connected to each other through friendships, and opinion leaders within those subgroups that might be the people that we focus on for an intervention strategy to diffuse new information, norms, or behaviors through that network. A second strategy is segmentation. And this is where we use network analytic methods to identify at-risk social groups. And so the network that you see here is from Christakis and Fowler's 2007 paper on obesity and social networks that showed how obesity really clustered within the Framingham Heart Study community network. So here you might identify clusters or groups of people that are particularly high risk, where the focus of the intervention is on group level change as opposed to change at the individual level. And so these interventions often include very intentional components that try to elicit communal coping processes, communication, increase support, and ultimately try to increase co-engagement and positive social norms and influence around behavior change, perhaps within family systems or within peer group or intervention group settings. Here's an example of this. It was in the New Yorker this last couple of weeks, a cartoon that's using mHealth to build social connectivity among a family system. And yeah, I just thought a nice illustration of where an at-risk social group, perhaps a family that was lacking in social support, and maybe these network processes may be targeted through some sort of mHealth intervention. And then lastly, a strategy that we commonly use in health interventions is alteration. And this is where you're trying to change the structure of the network that someone is embedded in to support their health. Often we're promoting healthy social selection, so encouraging people to form new social connections that's going to change the composition of the network around them in a way that is benefiting their health. At an extreme end of this, you could think of Alcoholics Anonymous, where that's a network intervention strategy that really tries to dissolve unhealthy social ties and form new social connections and a new network that's going to support drinking cessation. I often work in family systems, and so that is a bit extreme to think about, like dissolving all of the family relationships that don't support our healthy eating. So more often we're thinking about how can our interventions create a few new social ties to add on to the networks of the moms that we work with that changes, the balance, the composition of the network, and is really an adjacent social network that's going to support healthy behavior. And so we have very intentional group-based components where there's a lot of focus on, coming together in shared geographic spaces to form meaningful new social connections and co-engage in health behaviors and health support with one another in a way that we hope is lasting beyond the duration of the intervention, but that really meaningfully creates new social ties for people that are part of this intervention component. So this is my last slide. I want to end with what I think are some opportunities in this space. I think for observational research, I'd really encourage you all to draw on the rich literature of important social network features and mechanisms that are well documented to sort of be the premise of what network functions or structures or relationships might be most important for the work that you're doing. And then to use innovation. There is a lot of opportunity here to innovate on, I think, a very long tradition of survey-based research, but using innovation in mHealth, data science, and behavioral and social sciences to get richer and more precise insights into dynamic, contextualized, social and ecologically embedded mechanisms that are critical to health outcomes and really critical to health disparities. Again, I see this, the work of sort of really engaging with social and ecological factors as really so central to thinking about the barriers that many people and communities face to long-term behavior change. And this is a way to really help us understand those and people's intersection with them. For intervention research, there's really exciting opportunities for social network interventions. So as part of intervention strategies, certainly not necessarily the only thing that you would do, but as one ingredient in our interventions, there could be network intervention components that try to address or leverage or harness or change networks in some way that are going to support the adoption of health practices and their long-term maintenance over time. And there's a lot of exciting opportunities to use mHealth innovations in that space. The other thing I'd encourage with intervention research is really thinking about how to measure social network mechanisms of change. And so one thing that's been missing from some of our intervention literature is really measuring networks and network processes over time throughout interventions, so that we are really documenting, if the network process we intended to alter changed, and if that really mediates or plays a role as a mechanism of change in some of these outcomes. And there's a lot of opportunity to do that using mHealth tools to capture richer and more in-time and contextual information about these mechanisms. And yeah, lastly, to use this work to really inform more effective, actionable, and equitable intervention strategies that work for everybody. I will share these slides out, and I'm at the very last two slides, I have just a couple pages of resources about professional organizations. There's some really great tools for collecting network data. You can do this with Qualtrics or other REDCap tools, but using specialized network software can make it much nicer for study participants. And then some network analysis software, and some key books and papers applying this to health and health interventions. So let me stop there. And open it up for any questions.
I have a really practical question. I'm sorry if this is too basic, but I was curious as to in terms of looking for collaborators, in what types of departments are there people who do social network analysis research like yourself?
I think you can find them almost in a lot of different places. So sociology has been kind of a disciplinary home, or statistics. But I'm in a school of public health. There's a pretty big group of network scientists in our school, social work as well at USC. The professional organization I mentioned, the International Network for Social Network Analysis, is insanely interdisciplinary. There's statisticians, mathematicians, but equally organizational scientists, psychologists, public health folks, political science folks. So you can, you may have to search around to see where they're located because they could be hidden anywhere, but sociology is a good start. And there's been a few emerging like network science institutes and centers at different universities that become interdisciplinary hubs where network science is applied. So at USC, we have a Center for Applied Network Analysis that spans, 6 or 7 different schools. And I know there's other institutes across the US like that.
Great, thank you.
No worries.
Hi, that was just a great talk. I'm a trauma researcher, and so we do a lot of research into social support and how that really builds coping self-efficacy and all of that. But what we found in our research is there's a real disconnect between the behavioral components of social support, how many friends they actually have or how often they see them versus how they perceive strength of their social connections. And I'm wondering, do you have any thoughts on that? And has there been some research that you could point me to in that direction?
Sure. Yeah, I think that touches on sort of really doing some good preliminary work on understanding the functions of the network that is most important to your research question. I'd suggest you look up Amar Dahan's lab. He works in primary care at Harvard and thinks a lot about the personal networks of his patients and how to measure those practically in a primary care setting. And he, I know, has written and spoken on this issue of, just eliciting names or counts of people that people are connected to may give you just a snapshot of their social connectivity or if they're totally isolated or not, but asking questions about who, so that there's some standardized social network questions about important health matters or important matters. Often I'll adapt like social support measures to network questions because similarly, I might really want to understand, you may have these social ties and these family members, but who would really provide tangible or informational support to you if there was a crisis? And those sorts of self-report measures can be really important to understand like what is actually flowing through or their perceptions about what's flowing through the network. Yeah, does that get at your question a bit? And maybe the other point I think is like an opportunity to capture more sensor or passive secondary data on networks that I think gives us a snapshot into something a bit different than what you might get from those rich survey type questions about asking about perceptions and functions of relationships. And so my experience is trying to combine those two can give you some to measure different constructs within the network.
Yeah, you could be by someone a lot, but there's no deep connection going on or deep support going on. So,
yeah. And like the example for eating, we were kind of initially really focused on like who do they perceive as really influential or supportive, but actually just who they're eating with mattered a lot because a lot of the social influence mechanisms are pretty unconscious. And so, for that particular very habitual behavior, just shared exposure during eating events was a tie that we really needed to like try to measure in different settings.
Interesting. Well, that's great. Thank you so much. It's great talk. I appreciate it.
Thank you. Thanks.
If there are no other questions, can I ask one? Really lovely talk, Kayla. I'm really curious about, especially this last few slides where you talk about trying to get more at the mechanisms of social interactions, especially in these sort of interventions that we typically do more on the micro level versus massive population style. What is the granularity of the data that you actually need to understand these things, right? So because partly, when I listen to this talk, the things that come to mind to me is that just sort of there's massive differences in burden that both and technical requirements that you would need for different granularity of data. So if you're trying to get a teach interaction, like every time I text you or every time I talk to you, like that's a very different kind of a thing in terms of what is needed technically and what is needed in terms of intrusion into people's privacy and so on. Then if it's sort of summary is done, that if I ask you a couple of questions every day or every few days and so on. So I'm just curious, what is the level of the data that actually becomes useful for trying to map up about how these processes are unfolding over time? And that, there is that often we try to sort of get at a sweet spot. You're not going to get everything you want, but if you were to, given your experience, sort of say, okay, weekly data, like these processes don't change quite that quickly. So maybe if you can get some information weekly, that might be good enough versus do we actually need sort of within the micro interactions?
Yeah. That's a great question. Again, I think it's a bit driven by your research, and your research question is like, but I think a benefit of many social relationships that we're interested in for health are that they're quite stable. So especially if we're interested in relationships that have to do with social support, closer social ties, those are things that could be measured a bit less frequently. I think this question about the sweet spot is really hard. I know I've thought about this in different proposals where we said, okay, let's think about a sort of bounded family system where we could really kind of look at the small group pretty intensively. And we want to increase a communal coping process in this family, which is sort of a theoretical framework for changing behavior collectively, where we want to increase communication about this health issue among people in the family members, and then get them to appraise it as sort of a collective issue. And then we want them to start to communicate about that more and co-engage more in preventive health behaviors. And so, one intervention design where we've done that has been survey-based and very low intensity, where every 3 to 6 months, survey data is collected about those interpersonal processes and people self-report on them, and it was pretty low burden. And we found that we were able to shift those network mechanisms, and that in fact they mediated like behavior change at the end. But we've worked on intervention proposals where we thought about, it would be really great to capture this in more real time using mHealth strategies. Where could we passively, get everyone in the family to consent to use an app for communication or track their sensor data, where we could more passively observe co-location, co-engagement, and things like physical activity, for example, some communication patterns, perhaps through our app. And then in real time, we could do more interesting interventions, like kind of the New Yorker article I showed you, where we say like, hey, you guys aren't, really talking about your diabetes risk and what to do about it as a family. We could cue you more in the moment or at the right time. So those are things we've written proposals of and thought about, like how we might do that more intensively. And would it be valuable? I think probably, but that seems like an open empirical question. And I think the sweet spot may be like where we can find some mix of passively capturing some of this information that give us a bit more in time, right time intervention opportunity for those social dynamics, with getting some maybe richer self-perceived information through continued like survey stuff. But yeah, I think there's this is a great area to think about exploring, like where that sweet spot is. But yeah, maybe the other point I'd just make is like those, close supportive relationships that are fairly stable, they evolve and change more slowly. But when I'm thinking about eating events, we've really thought about like, okay, there's value in capturing population mobility data just to see like who's in shared restaurants together and kind of exposed to different people, even at a population level. If we can sort of get some mixing matrices for something like LA County, there is some evidence of like those social exposures also kind of giving us normative influences on eating and affecting maybe what we buy in a given location based on what others are eating there. So yeah, I think depending on the mechanism or the social function, the granularity, the value of the different granularity of data may differ.
Very cool. Thank you. Any other last minute questions for Kayla? Otherwise, we'll give you guys a break so you can get lunch, and then we'll see everyone back at I think it's noon. Is that right? Noon Pacific,
Yes.
3 o'clock. Yes. All right.
Thank
Thanks
you.
everyone for
Thanks
attention.
all.